Hope you're all doing well. Good. So, Alita, continue. It's been extensive, but I'm really hoping that it's making an impact in your knowledge acquisition. Right. So, we dealt with the factors that could affect somatogenesis. And an area we mentioned was about hormones. And the impact of hormones on spermatogenesis, I felt, require more extensive explanations. And so we are taking that one out and expatiating just as we did for syphilis. So we could have just mentioned that hormones and for that matter, testosterone can have effect on sperm production. But to what extent? All right. So let's move on. So, hormonal study is called endocrinology. All right. Because normally you have the endocrines that produces hormones. All right. So I'm sure all of us at one point in our study, especially in biochemistry, did endocrinology. So just that aspect of that study and how it impacts on sperm production. That is what we are doing at this session. All right. So you might have come across what we call the HPG. That's the hypothalamic pituitary gonadal axis. All right. So it is this triangle that actually regulates sperm production, and for that matter, male reproductive system. So the entire hormonal system begins with the release of gonadotropin-releasing hormones. And that one, as to how it is triggered, I mean, we don't know for now. So the hypothalamus, where is it situated? Okay. Right. So it is this gonadotropin-releasing hormone, which we say is coming from the hypothalamus, which actually also prompts another gland called the pituitary gland. All right, but they are all located at the same side, below the base of the brain. All right, so one is on top of the other. Of course, the hypothalamus is on top, and then the pituitary is below. Right, so the gonadotropin-releasing hormone is actually released from the hypothalamus, and then it hits on the pituitary gland. And even the pituitary gland, we have the anterior and then the posterior. Here, our emphasis is on the anterior because that's where the gonadotropin-releasing hormone actually targets. Once it gets there, then the pituitary will produce luteinizing hormones, which is very familiar to us by now, and then the follicle stimulating hormones. All right. So the gonadotropin-releasing hormone prompts the pituitary gland to secrete the FSH and then the LH. And all of us know that the LH, their target is at the lady cells. I think you've always mentioned that you can use this as a mnemonic, that's something to help you to remember. The L and the L. So the LH will go to the lady cells, okay? And the FSH will also go to the S, which is the Sertoli cells. And by now, you also know where the Sertoli cells are located, and you also know where the lady cells are also located. They are all in the testes, but they are located at different positions within the testes. All right, so the LH targets the lady cells, which are within the interstitial space. And once they do that, then the lady cells will now also be stimulated to produce and release testosterone. Okay. Then the FSH will also now go into the seminiferous tubules, and then also their target is on the Sertoli cells. Okay. So what they do immediately is that once the FSH hit the Sertoli cells, remember Sertoli cells produces what we call the ABP, androgen binding proteins. All right, so they will produce the androgen binding proteins, which will serve as receptors to receive the testosterone, which will now be produced by the lady cells, which is just outside the next door. I mean, just after outside the seminiferous tubules, you have the lady cells. They are producing the testosterone. So then they will push into the seminiferous tubules, where by this time the Sertoli cells, under the influence of the FSH, will have produced the androgen binding proteins. So it is this androgen binding proteins that will serve as the receptors. So ABP, which is the androgen binding proteins, which has just been produced by the Sertoli cells under the influence of the FSH, will now serve as receptor to receive the testosterone, which has also just been produced next door, just outside the tubes by the lady cells. I hope that you are following. Once you follow it and you understand, it's 6, and that is all. Now, because the ABP is just within the seminiferous tubules, remember the ABP has just been produced by the Sertoli cells, they will capture the testosterone which has been produced. Remember that as we move along, you see the S2 significance. So in that case, a lot of the testosterone will have been contained or retained within the testis itself. Okay, so you just get few, just very little, which is now going into the bloodstream. Okay, so in that case, it creates a high intratubular testosterone concentration. So I've bolded that high intratubular because it is within the tubes, the seminiferous tubules, and for that matter, the androgen binding proteins are all within the tubes. So they are concentrating, they are binding the testosterone. So it's the highest concentration of the testosterone is now being retained within the tubules. So they become intratubular testosterone. So they don't get access into the, remember, within the tubules, they don't get access into the blood, to the blood cells because of the extensive blood testis barrier. Okay, so almost everything will go into the tubes. So we create high intratubular testosterone concentration within the seminiferous tubules. This is to support the spermatogenic germ cells maturation. Remember, we said that spermatogenic cells are the germ cells. So initially they will be primordial or inactive. So under the influence of testosterone, they begin to mature. And then from there, then they'll go into the mitosis. All right, so that is where the sperm production or spermatogenesis now also begins. Okay, now so it is on record that the intratesticular testosterone levels will be approximately 50 times, sometimes even up to 200 times higher than the levels found in blood. I think this is also very important to also appreciate. Right, so this is the HPG, that's the hypothalamus. So the hypothalamus is at the base, this is the big brain. At the base here, you have the hypothalamus, and just down it, you have the pituitary. All right, so the hypothalamic pituitary gonadal, which is the HPG axis, serves as the primary endocrine control system for spermatogenesis. The hypothalamus and pituitary gland are located at the base of the brain, yes, here. And of course, the gonads, right? You're talking about the hypothalamus, pituitary, and gonads. You know where these two, where they are in the brain. What about the gonads? The gonads is just the testis. Okay, so when you're talking about the male gonads, you're talking about the testis. And then when you talk about the female gonads, then you're talking about the ovary. Okay, right. So here, you can also call it hypothalamic pituitary testicular axis. Okay, testicular, because now you are making it specific that you are dealing with the testicles. But the more general term is the gonad. Okay, so either the gonads or testicles, they are the same thing. All right, so you have it here, and then the hypothalamus will produce the gonadotropin releasing hormones, which will hit on the pituitary. And then the pituitary, under this influence, will release FSH and the LH. The FSH and the LH are this is commonly called gonadotropins, because these are hormones that are having the effect on the gonads, which is the testis. They have their effect on the gonads, so they are called gonadotropins. So if you say gonadotropins, you haven't said anything. Okay, you haven't said anything. But if you say FSH and LH, then you are become more specific. But if you say gonadotropins, it could also be FSH, it could also be LH, because all of them are going into the gonads. Okay, so they are hormones that are targeted towards the gonads. That's why they are called gonadotropins, gonadotropin hormones, or simply gonadotropins. And there are two of them, FSH and the LH. So once they come into the testis here, that's where FSH will go into the tubules. And then the LH will also be the interstitial or the tubular, where you have the Leydig cells. Okay, and I've kept on saying that the LH is going to stimulate the Leydig cells. And the Leydig cells are also called interstitial cells because they are within the intertubular space. So since the LH is going to stimulate the Leydig cells, you can also say that the LH is going to stimulate the interstitial cells. So therefore, that's how LH is also called interstitial cell stimulating hormone. Okay, so that I think I've said this severally. So you will now appreciate why LH is called ICSH, interstitial cell stimulating hormone. All right. Then we're saying that all of a sudden, then you have the hypothalamus beginning to release gonadotropin releasing hormones. So when that happens, what does it trigger? So then we come into the element of puberty. Remember, in all of this, there are female, we're dealing with the reproductive system, okay? We are concentrating on the male because it's andrology. So you can also have the gynecological aspect where you'll be dealing with the female. All right, so puberty, of course, you know that you also have puberty in females. Here, our concentration is on the males. So puberty in males, just have some few lines about that. So puberty is the process of physical maturation in males, typically beginning between 9 to 14 years. All right. So the age is lower in females. So in females, I think it's from 8 to 13 or so. All right. So in males, it's typically around 9 to 14 years. That's the period of puberty in males. That's what we call precocious puberty. Precocious puberty is the same thing as early puberty. And this refers to the condition where the puberty starts earlier than the 9 years. Because we're saying that the age range is from 9 to 14. There are some people who can begin puberty, let's say 8 years, or for the males, or 7 years. Okay, that's how come you can have some females, if the puberty is supposed to start from 8 years, normally from females. Some can have it as early as 7 years. And so it is not impossible for 8-year-old girl to, because by that time, as soon as you get the puberty starts, I mean, that is also the beginning of menstruation. So similarly, as we have puberty in males, It's also the beginning of spermatogenesis. Okay, so it means that if you have somebody who can also have puberty starting earlier, let's say 8 years, then you can also have an 8-year-old boy also fathering a child. All right, good. So when you say precocious puberty, if it's males, it's anything less than 9 years. If it's a female, that is also anything less than 8 years. Okay. Now you can also have late puberty or delayed puberty. And so for males, it is also once after 14 years, the person is not showing any signs of puberty. And what are those signs? You also look at all those things as you move along. So you have early puberty, which is precocious puberty. Then you have late puberty or delayed puberty, which is any age from 14. All right. So he said that now at puberty, you are going to expect a lot of changes, including sperm production. Okay, including sperm production. Then that's where, so when the sperms are produced, where should they pass? They should pass the tubules. So seminiferous tubules develop, the central lumen will develop after puberty. That's also very important. That's how come you cannot get a boy who has not started puberty to produce sperms. It is also not possible because physiologically, the body will not allow, even if the sperms have been produced, they will still remain within the testicles because the lumen, the tubular lumen have not been opened up yet. Okay, that's also very, very significant thing to note. All right. So again, then you see, let's see how the hormones will trigger puberty. So like we said, the hypothalamus will trigger the start of puberty by releasing the gonadotropin releasing hormones. In a pulsatile manner, what it means is that it comes in pulse. So it will come, okay? So that is, as you move along, that's how come you're also going to get testosterone being produced in a certain faction. I mean, it's not like the production is not it's not even, okay? Because what is going to cause it to produce is not also released in full. It is in pulses, yes, in pulses. All right. So when the gonadotropin releasing hormone is released in pulsatile manner, that's in pulse, that's in bits and pieces. Good. So, and we said that hormone, the gonadotropin releasing hormone, will stimulate the anterior pituitary to produce LH and FSH. That's also very, very significant. It's the same thing as we've said over and over again. Now you're talking about how it starts in a young boy, okay? And the same thing as it is in an adult. Right. So the increase in the LH will, of course, stimulate the lady cells to produce testosterone. That's also fundamental, which you know already. As the testosterone keeps rising, by this time, you realize that the body has not fully gone into sperm production. Okay, once it hasn't gone to full sperm production, there still be enough of the testosterone to move into the bloodstream. Remember, we said that once the once sperm production is in full force, then the Sertoli cells will be very active. Then once they are very active, they will produce a lot of, they will need a lot of the testosterone. So they will produce a lot of the ABP, which is androgen binding protein, to attract or bind all the testosterone which is coming into the blood, which is being produced by the lady cells. And therefore you have very little left for the bloodstream. But now, because in the early stages of puberty, spermatogenesis is not fully in force. And therefore, you get a lot of the testosterone being in excess to go into the bloodstream. And this bloodstream level is what is now going to trigger the development of what we call the secondary sexual characteristics. I hope that point is clear. That should also be understood. Okay, so the rise in testosterone will promote the growth and functional maturation of the testes and puberty. In puberty. But now the testes will have to be developed. The seminiferous tubules will have to also be fully matured and stuff like that. So it's going to take some time for them to begin full-blown sperm production. That's how come you have excess of the testosterone being available in the bloodstream to be able to also now use for the development of the other secondary secondary sexual characteristics. So testosterone levels vary considerably among individuals based on age. So you have the pre-pubertal levels. Pre-pubertal, of course, before puberty, the levels are very small, which is less than 30 nanograms per deciliter. So in early stages of puberty, that's where now all of a sudden the testosterone, gonadotropin releasing hormones begin to now function. And then, so at that point, testosterone level will begin to go up. So they'll go up to about 3-4 times the pre-pubertal levels, which is from 30 to 100, okay? And then the mid to late puberty, now they are getting higher, about 10 times the initial stage, okay? So all we are establishing is that during puberty, the testosterone levels increase very significantly, and levels will peak up to 1,200. So it means that at this time, they're having more of the testosterone in the bloodstream, okay? Once they are there, then let's see what happens. So the consistent increase in testosterone is a hallmark of male puberty. So the increased testosterone levels trigger the increased testosterone levels will trigger the major physical changes that is associated with puberty. And that will include, first and foremost, testicular size increment. There's going to be the test, because now we are saying that the testes will have to develop to begin to become matured and develop to be able to be producing the sperms. So the seminiferous tubules and all those things they are now being strengthened, so or being matured. So they will become bigger. And once they become bigger, then of course the scrotum will also be big. But unfortunately, you are unable to see at somebody's testes and see whether there's an increase in size or so. So you often don't see that much. What people see most is hair on your pubic area, which we call the pubic hair. That's what you see. But before the pubic hair comes in, the first sign of pubertal change is actually testicular increase in testicular size. Okay. And once the testicular size is increased, automatically there's going to be enlargement of the scrotum. Okay. And then there's also the growth of the penis. Remember, we said that the penis will begin to grow during puberty. So there's also growth of the penis. And of course, there will be growth of pubic hair. And I said that's what most people look at. And then as we move on, there's going to be facial hair growth. There's going to be a voice change where now the small boy will begin to speak like a man, deepening voice, which we call cracking. Okay, so the voice is like changing from when a child is talking, especially when on the phone, if you call somebody, if a child picks the phone, necessarily you see that this is a child voice. Okay, once you reach puberty, all of a sudden the voice will change automatically, especially if it's a male. The voice will change automatically and becoming deeper. And then it doesn't look like a small boy's voice any longer. These are all signs of the physical changes associated with puberty. There's also increased muscle mass and of course libido, because testosterone will also be going high, and testosterone is also one of the things that will also increase somebody's libido. Okay, so all these things will be found in the young boy, and they are normally called the secondary sexual characteristics. Okay, right. So it is also important to know that the first sign of puberty in boys is increase in testicular size. It's also very, very important. Unfortunately, because we don't scrutinize people's private parts, you may not see it. But for scientific point of view, it's important to learn that actually the first sign is in puberty is increase in testicular size. Pubac or pubashi is, is pubic area. Okay. And pubic, of course, pubic area. That is I don't know how to explain it. That is the side and on the below the abdomen, and then just on top of your penis, that's your pubic area. And so the hair there is called pubic hair. All right. Puberty is the first appearance of pubic hair, just as you have menarche. What is menarche? You can tell me. Menarche. First menses. Yes, first menses. Okay, so puberty is first hair on the pubic area. Okay, it marks the first physical pubertal sign in boys, often alongside testicular growth. But I'm saying the first ever thing is the testicular size, but we don't normally look there. What you normally will see first is there. Once you see some small hair on the, say, hey, I mean, you are becoming a big boy, then that is puberty. All right. But before this time, there's already been a testicular size increase. Okay. Take approximately 2 years. Okay. Following the puberty, and then you also have hair begins to grow on the legs, the arms, axillary, and then now the otherwise small boy becomes a big man. Okay. Right. So those are some of the things that you got to know. They are very, very fundamental, and in all biochemistry subjects, you learn endocrinology, and this is just a small aspect of the entire endocrinology that you may be learning. Okay, right. Then there's also what we call the feedback mechanism. In all endocrinology studies, you have negative feedback mechanism, or what we call the feedback loops. Okay, right? Because if you don't take care, if hormones are being produced and produced, if you don't take care, they also end up to be something else. So as they are increasing, they will now go and hit something, and that something will tell whatever is causing the increment to slow down. Okay, and then that cycle will repeat itself. Okay, so that's the negative feedback mechanism. So in the hypothalamic pituitary gonadal axis system that you talked about, there's also a feedback system or a feedback mechanism, right? Now here, we talked about testosterone. Testosterone, all of us know that testosterone is coming from the lady cells, okay? And then they will be concentrated to a large extent in the intratubular space. But you still have some, you still need some for the body system. So some will still have to be available in the bloodstream. Okay. Now, if the bloodstream level goes high, then you should tell the hypothalamus that yes, the lady cells is overproducing. So do something about it. So what do you think will happen? Once you have high testosterone going up, it gets send a signal to the hypothalamus that there's too much testosterone which is coming into the system. So let's bring it down. So in bringing it down, what do you think we'll do? The hypothalamus, what do you think we'll do? There's high amount of testosterone, and then send a signal to the hypothalamus. What do you think the hypothalamus will do? Yes. Somebody should help me. There's high amount of testosterone, and it sends a signal to the hypothalamus. What will the hypothalamus do?
I think the hypothalamus will try to compensate its production.
How? How? Compensate it to what extent?
Reproducing.
Oh, try it. I mean, I'm getting you. I just want to.
In order not to be a bias, I think it will first have to maintain a stable hormonal balance for all the hormones.
The hypothalamus will reduce.
Yeah, it should reduce.
The
It should reduce because the testosterone will only be produced under the influence. The testosterone will be produced by the lady cells under the influence of FSH. Okay, sorry, under the influence of the luteinizing hormones. Okay, now the luteinizing hormones is coming from the what do you call it? The it's coming from the pituitary. Let's take it again. Let's take it again. You are having testosterone and going up, up, up. And we say that what the testosterone does is to send a signal to the hypothalamus. Okay. Once you get to the hypothalamus first reaction is to reduce the amount of gonadotropin releasing hormone that is being produced, because the hypothalamus don't have direct control over the testosterone or the lady cells. It has control over the pituitary. Okay, so what to do is to reduce its production of gonadotropin releasing hormone. And you know that the pituitary will also respond based on the information is getting from the gonadotropin, sorry, the hypothalamus. Okay, I don't know whether I'm confusing myself or confusing you, but let me take it again. Once testosterone is high, it sends a signal to the hypothalamus. Okay. Now, then the hypothalamus will want to stop the high testosterone level, but it doesn't have direct access to the lady cells, which is producing the testosterone. So he will do it indirectly by reducing its production of gonadotropin releasing hormones. Once that happens, then it means that the amount of gonadotropin releasing hormone coming to the pituitary will be low. Once that is low, then the amount of LH and FSH, which the pituitary is also produced, will also be low. As soon as that low amount of lady cells the LH is low, then low amount will also now hit the lady cells and therefore will begin to reduce its production of the testosterone. That's how it is. Please, you go about it in your own way, in your mind. That you are talking about a situation where testosterone level is high. Testosterone level is gone too high. Once it goes too high, it sends a signal to the hypothalamus. That's what we call the feedback. But this feedback, how does it do? So the feedback is going to cause, and the end product is that it's going to now cause the testosterone to come down. So it means that this feedback is going to give you a negative response. That's what we call negative feedback. Okay. First, it will send a feedback to the hypothalamus. Hypothalamus, there's too much of the testosterone. The hypothalamus don't produce testosterone, but they produce gonadotropin releasing hormone. So they will reduce the amount of gonadotropin releasing hormones, and that will also mean that very little of the gonadotropin releasing hormone now comes to the pituitary. Pituitary's production of the LH and FSH is based on the stimulation from the gonadotropin releasing hormone. Once the release is now low, then it means that there's also going to be low LH and FSH. Okay, once there's low FSH and low LH, it means there's now going to be low production of the testosterone. And it means that by this means, testosterone level will now begin to go down. I hope that is something better. I hope that once you take your time and go through it, you appreciate it. So the elevated blood levels of testosterone provides a negative feedback to the hypothalamus. Okay, it is becoming negative because once something is increasing, we say it is positive. Once it is coming down, then it becomes negative. So the feedback message that is sending to the hypothalamus is going to cause a reduction in the products of the hypothalamus and eventually the product of the lady. So it means that at the end of the day, you are going to get a negative responses. That's why it is called negative feedback. Okay, negative feedback. All right. So the elevated blood levels of testosterone provides a negative feedback to the hypothalamus. Curtailing means like bringing it down. Okay, curtailing the release of gonadotropin releasing hormone, and consequently, because once the gonadotropin releasing hormone has been curtailed or reduced, then consequently LH and FSH secretion will also be reduced, because the gonadotropin releasing hormone will also now go to the pituitary, which will also produce LH and FSH based on the influence from the gonadotropin releasing hormone. So eventually, you are going to get low LH and low FSH. And that will now modulate or reduce the testosterone synthesis. Okay, so that's very nice thing about negative feedback mechanism. Right. Here, I just want to use the words upregulate and downregulate, because as scientists, occasionally you may find yourself in a certain exams or somewhere where you are talking about a downregulation of hormones or upregulation. So if you have an LH which is rising, of course, what will rise? If LH is rising, what will rise? Testosterone will rise. So it means that you are up regulating the level of testosterone. So a rise in LH stimulates an increase in testosterone production, which means that testosterone will be upgraded. Let me put that way, upgraded. So we use the word up regulation when something is able to push something up. Okay, so a rise in LH will up regulate testosterone. Okay, just as we also talk about the testosterone. If testosterone goes up, okay, it is also going to down-regulate gonadotropin hormones. Do you agree? When just as we met just some few moments ago, we mentioned when testosterone goes high, its effect is that gonadotropin releasing hormone will come down, LH and FSH will come down, and then testosterone will also still come down. So once all these things are coming down, we say you are down regulating them. So I just wanted you to appreciate the technicalities which sometimes you come across in endocrinology sessions. So when you say down regulate, it means that whatever is happening is bringing something down. If you say it is up regulating, it means that whatever is happening is also causing something to go up. That's all. That's all. So a rise in LH will automatically lead to a rise in testosterone. And we are saying that that is, in other words, you can say that a rising LH will up-regulate testosterone. Okay. A rising testosterone, like we said over and over again, provide a negative feedback for the gonadotropin releasing hormone, subsequently decreasing testosterone secretion. And so you can say that a rising testosterone will also down-regulate LH. I hope that you are not confused. A rising testosterone will down-regulate LH because the rising testosterone will cause the hypothalamus to reduce gonadotropin hormones, and then gonadotropin releasing hormones, and then pituitary will also now reduce LH and FSH. Okay, so that's how come they are using those terms. So upregulate and downregulate should not be confused at all. Wherever you meet them, not just in any endocrinology system, you will meet downregulation and then upregulation. And that is why I wanted to bring it down here so that once you understand it, anywhere you meet it, you wouldn't find one thing. If testosterone is low due to lady cell dysfunction and LH and FSH levels, let me take that one again. If testosterone is low due to lady cell dysfunction, LH and FSH levels will be increased. This is referred to as primary hypogonadism. And let me explain this one. Anytime you are talking about testosterone, we use the word gonads. Okay. So once the gonads, for that matter, the testis is the one which is producing testosterone. Just as you can also refer to testosterone as androgens. The function of the testis, as we read from in andrology course, is to produce androgens, which is testosterone, and also produce sperms. This is the primary function of testis. Okay, and the testis is the gonads. So the activity of gonad is gonadism. When the activity of the gonads, and for that matter, goes down, become hypogonadism. Just as if the activity of the testis becomes increased, becomes hypergonadism. The gonad refers to the testis. The primary function of the testis is to produce androgens, which is testosterone, and also sperms. Okay. Now, so the activity of gonads is called, or testis, is gonadism. If for whatever reason the activity has gone down, it is hypogonadism. If the activity goes up, it becomes hypergonadism. Good. Now, the activity of the gonads, which is gonadism, and it's primarily, now we are dealing with the enzymes or the hormones. So we are dealing with the aspect of hormone production, which is testosterone. If testosterone goes down, how will we refer it? You can say it is hypogonadism. Is that not it? Hello? If testosterone goes down, can't you describe it as hypogonadism? Yes, because
Yes, we can.
the activity of the gonads is to produce testosterone. Testosterone has gone down. It means that the activity of the testes has gone down. So that's hypogonadism. Anytime there is low level of testosterone, you call it hypogonadism. Now, if there's hypogonadism, two things can happen. Either is supply, because for the testes to produce the androgens, and for that matter, testosterone, there must be LH. Is that not it? There must be LH. If it doesn't get LH, it will not be stimulated to produce the testosterone. Now, if you have a situation where the LH is there, the LH which is in good supply, yet the production of testosterone is low, then it means that the cause of the hypogonadism is from the testis itself. That becomes primary hypogonadism. You have what it takes to produce, yet you are not producing. It means that the problem is your own. I hope that point is clear. The testis is supposed to produce testosterone. The thing that he needs, which is LH, to produce the testosterone, even forget about the FSH for now. But FSH is dominantly for the sperm production. As for the testosterone production, it is the function of the LH. I hope that point to you is clear. It is the function of the LH. So if you have enough LH, yet you are not producing, you have a factory, you are supposed to produce, you have all the, what do you call it? how do you even the ingredients or materials to produce, yet you are not producing, then the fault is coming from you. You can't say that, oh, I don't have what it takes or what I need to produce. Okay, so primary hypogonadism is a situation where the supply of luteinizing hormones is adequate. So if you do, if you have low testosterone, okay, and it's just like if you have a low HB, the doctor wants to know whether it is due to hemolytic or non-hemolytic, but ask you to go and do retics. Okay, so if you have a low HB, you go and do retics, and retics is high, then it means that there is a hemolytic factor involved. Okay, so you go and do testosterone. Testosterone is low. First and foremost, you want to find out whether the testis, which is supposed to produce the testosterone, has what it takes. It has the stimulant to produce. So you go and check for LH. You even do FSH. You go and do LH because it's LH that is supplying you, that is stimulating the lady cells to produce the testosterone. Okay, so if you do your LH and LH is normal, what condition is this? You do your LH, do your testosterone very low, you do your LH, LH is normal. What condition is this? The question again, I'm saying that.
It's still primary,
yes, primary hypogonadism. Stanley, if you follow the discourse, you should be able to get some of these things right away. Okay, because we are saying that the gonads, which is the testis, their primary function is to produce androgens, which is the testosterone, and also produce sperms. If it comes to the androgen aspect, which is the testosterone, we don't talk about FSH because the testis don't need FSH to produce the testosterone. I hope that point is clear. Even though the LH and FSH are all coming from the pituitary under the influence of the gonadotropin releasing hormone, but when it comes to production of the testosterone, we don't need FSH. You rather need the LH. So if your testosterone is low, you have no business doing FSH. Okay, you have no business doing FSH. But if, let's say, now you still want to, you are doing the hormone because the person has low sperm count, and therefore you are doing that. That is a different thing. Here we are talking about, let's say, you want to find out whether you're dealing with primary hypogonadism or secondary or something else. Then you have to do LH and not FSH. This is the point I want to establish, because the production of the testosterone don't need FSH, they need the LH. So if you did your testosterone, it was low, you want to find out whether it has the stimulant, what it is required to produce the testosterone. So you do your LH. If the LH is normal or even high, then it means that you are dealing with the testis itself having a problem. That is primary hypogonadism. It means that the lady cells themselves are dysfunctioning. They are not working, not because they don't have the stimulant. The stimulant is there. Normal LH or even normal or even high LH. But say testosterone is low. It means that the lady cells themselves are not performing. So that is what we call lady cell dysfunction. Once you are able to establish the fact that LH is normal or high and testosterone is low, you can conclude that you are dealing with a situation of primary hypogonadism, and therefore it is a testicular problem. The testis itself has a problem. All right. Now, there's also another interesting thing that happens. The Sertoli cells. We said the important role the Sertoli cells play. In that case, it plays the role is specific for the sperm production and not for the testosterone. Okay, good. So when it comes to the sperm production, we are dealing with the Sertoli cells. The Sertoli cells will also produce, apart from the androgen binding proteins, which will attract the testosterone into the tubules for it to help in the maturation of the germ cells. The Sertoli cells will also produce an enzyme, sorry, a hormone called inhibin. Inhibin will still mean inhibit, or therefore like stop something. So inhibin. Now, this inhibin will be produced once you have too many FSH, because it's the FSH which I hope that you people are getting me correct. The LH and FSH are all coming from the same source, the pituitary. LH is going to the lady cells to produce the testosterone. FSH is coming directly into the tubules to help in sperm production. If sperm production is becoming too much, or yes, and then the body wants to, or the seminiferous tubules wants to restrict or reduce the amount of sperm production, what we to do is to produce to produce an inhibin. Inhibin will now also serve as a negative feedback to go and tell the pituitary. Okay, in this case, you would tell pituitary not to produce much of the FSH. Okay, it will not. It will go and tell. In fact, from the system, it will go and hit the gonadotropin, the hypothalamus, and also hit the pituitary. But here, the influence is still more on the FSH, because you know that if you reduce LH, it will still not help the production. So its import or its effect is more on the FSH. Okay, so the inhibin will have more effect on FSH than the LH. I hope you are getting me, because the activity is happening within the seminiferous tubules. Okay, Sertoli cells are within the seminiferous tubules. He's feeling the heat of more overproduction of sperms. So if it's getting too much of the sperm being produced and want to stop it, then we need to stop FSH. If he needs to stop FSH, then it cannot rely on testosterone, because testosterone is under a different route. So what to try to do is to cause a reduction in the FSH. So it will produce its own inhibitor, which is called the inhibin. So the inhibin will go and hit both the gonadotropin releasing hormone and also hit the pituitary and tell them to reduce their, and now it will tell them that, look, even though you are producing both the pituitary, you are producing both LH and FSH. But what is important to me now is the FSH, because FSH is worrying me too much. So now reduce the concentration of your FSH for me. Okay. As opposed to the testosterone. Testosterone will go there and it's like, me, I don't need much of the testosterone. So please, gonadotropin releasing hormone, tell pituitary to reduce the amount of the things that is sending. So there can be a reduction in both the LH and the FSH. Now with the inhibin is more targeted. Inhibin will say that me, if reduce the FSH for me. So the attack, the feedback on the FSH with respect to inhibin is greater on FSH more than LH. Please, are you following the discussion?
Yes, sir.
Yeah. It is very complex, but I'm hoping that you get. And this is the same thing if you're doing any biochemistry. I'm not sure any biochemistry tutor will even take time and explain this over and over again. But it's a special course, and it's also just for the reproduction. That's why. But once you understand it, it can expand to any of the other hormones, and it's the same thing. So inhibin produced by Sertoli cells when sperm production is adequate, specifically inhibits FSH secretion from the anterior pituitary without affecting the LH. I hope that point is clear. This works alongside testosterone negative feedback. So once sperm production is adequate, let's say you are getting more of the sperm being produced, the body will still have to find a way of stopping it. So they will need more attack on the powers that be. The powers that be are the hypothalamus and then the pituitary. So you need to send them signals that please, we don't need much. So at the same time, the LH can also, since the Sertoli cells is rejecting the FSH, it means that it's also going to reduce the amount of androgen binding proteins that they are producing. And therefore, the requirement for testosterone will also be low. And so it means that the testosterone too will also be also acting on the gonadotropin hormones and then the pituitary. All of them will combine their, let's say, combine forces. They will combine their forces. The inhibin and testosterone will combine their forces. Now, at the end of the day, the sperm production can come down. Testosterone too can come down, and you have the what we call the homeostasis, normal balance of hormonal activity. All right. So in effect, inhibin and testosterone will feed back on the pituitary to down-regulate FSH. Okay, I hope that point two is clear. Okay. So if Sertoli cells are dysfunctional, spermatogenesis may be hindered, and an elevated FSH may be a marker for such an injury. What you are saying here is that if Sertoli cells become dysfunctional, just as we talked about the lady cells, if the lady cells are dysfunctional, then once they are dysfunctional, they will not be able to produce enough testosterone. But if you want to know whether the lady cells are dysfunctional or they are lacking LH, then you check your LH status. If LH is normal, then you are saying that, okay, then you have dysfunctional lady cells. The same way, if you have a problem with the Sertoli cells, if the Sertoli cells are dysfunctional, then you go and check your FSH. You see the FSH is normal. Okay, the FSH is normal. If FSH is normal, yes, Sertoli cells are not producing the enough sperms. Then the problem is coming from the Sertoli cells. This is the way to understand them, so that you don't just do the test. You say, oh, do FSH or do LH or do testosterone. You just create the results, and then you yourself cannot interpret them. But once you have this understanding, you get the results and can do some interpretations. Oh, my LH is low, and then my FSH2 is also low. Okay, then once they are low, it means that the problem is coming from the source of production, which is the pituitary. Okay, something like that. All right. Now, it is also important to know that the pituitary, which is producing the LH and FSH, is the same pituitary that produces prolactin. Okay, right. The same pituitary produces prolactin. Now, prolactin is stimulated by estrogen and thyrotropin releasing hormones. The thyrotropin releasing hormones will also cause the T4 and then the T3s to produce. Okay, this is more of biochemistry, and you have to bring your mind to that aspect. So the pituitary gland, which secretes the LH and FSH, the same one also will secrete prolactin. So if you have high prolactin, it will also serve as a negative feedback on the activity of the pituitary. And therefore, they will end up giving you lower levels of the gonadotropins, which is the LH and FSH. So that's how come if you have, remember we said that in the obese, you have the enzyme aromatase, which will convert testosterone into estrogens. These estrogens now become a negative feedback on the pituitary. So once they become negative feedback on the pituitary, it means the pituitary cannot produce enough LH and FSH, and therefore they will also not produce enough testosterone and also not enough of the sperms. Similarly, if you have hyperprolactinemia, high levels of prolactin, prolactin is also going to have a negative feedback on the pituitary. And then the pituitary will also give you lower levels of LH and FSH. So that's how it is important that if a doctor is investigating a cause of, let's say, infertility, and is suspecting a hormonal cause, you see that you'll be doing LH, you'll be doing FSH, you'll be doing prolactin, you'll be doing the thyroids. Why? Why would they do that? So with this interpretation, you see that, so the patient is being investigated for infertility. And I don't understand why the doctor is doing the thyroid. Because the thyroids, as we move along, thyroids, they have effect on the pituitary activity. And the pituitary will also have effect on the production of LH and FSH. So any of those things, if your thyroid is up or low, and prolactin is up or low, they all have effect on the activity of the pituitary. And the activity of the pituitary will also have effect on the production of LH and FSH. And the production of LH and FSH will also result in testosterone and then FSH and so forth and so on. So those are the dynamics which you have to try to understand. So the same thing. So prolactin is a potent inhibitor of gonadotropin-releasing hormone. Okay. And once that happens, it means that it will cause low levels of LH. And then once they cause low levels of LH, automatically they will cause low level of testosterone. And then so forth. So in effect, hyperprolactinemia will give you low testosterone automatically. Hyperprolactinemia will give you low testosterone. And then of course, can have a negative impact on sperm production. So this is it, the endocrine feedback loops. So you have your gonadotropin, so the hypothalamus, which is in the base of the brain, and the pituitary, which is also in the base of the brain, but this is up and this is down. So this one will begin to produce the gonadotropin releasing hormones, and then the pituitary will also, under the influence of the gonadotropin hormone, pituitary will release LH and FSH. Okay, the LH is coming to Leydig cells, and then the FSH is coming to the Sertoli cells. Once the LH comes to the Sertoli cells, they will facilitate or promote spermatogenesis. LH is coming to Leydig cells for what? To promote or facilitate production of what? Hello? Testosterone. The testosterone will, you see this, will also go to the Sertoli cells because testosterone will be required for the maturation of the germ cells. Okay, and then the FSH will also be in support. So the FSH is working alongside testosterone for spermatogenesis. Okay, so, and then if there's high amount of testosterone, then they will negatively work on the hypothalamus and the pituitary. So you see this is a negative, this is a positive. The positive means that it has a positive effect on the Sertoli cells. Pituitary will have a positive effect under the influence of gonadotropic releasing hormone to give you LH and FSH positively. The Sertoli cells for sperm production, to the lady cells also for testosterone. The testosterone will be required to support the sperm production. If the testosterone is too much, of course, they are too much, they will show in the bloodstream. Then they will give a signal to the pituitary and also to the hypothalamus. What it means here is that this one will reduce. Once this one reduces, then the LH and FSH will all reduce. And then, of course, the cycle will go on like this. Then we say that apart from the testosterone, here you are also going to have, the testosterone is also going to produce inhibin, because if you rely on the testosterone alone, the testosterone alone cannot cause, if there's too much sperm production, the testosterone is not coming from here, and therefore its impact will not be felt. So the Sertoli cells will produce its own inhibitor, which is called inhibin. So the inhibin will now hit on the anterior cells, anterior pituitary, and then cause it to reduce the production of FSH and not the FSH and LH. Okay, so you see how it works. So now once it gets a negative feedback on this one, then FSH will also become low. Once FSH becomes low, sperm production will also be low, so forth and so on. So once you understand these dynamics, I'm sure anytime, anywhere, any question on hormonal regulation of sperm production, or for that matter, male reproductive system, you should be able to get a grips of it. The same thing here. There's another picture of the endocrine feedback loops. Okay, here you're talking about the brain, and then where you have the hypothalamus and then the pituitary. Okay, the same system, with different pictures. Let's talk a little more on the testosterone. You know by now very well that LH produced by the anterior pituitary binds to receptors on the lady cells, and then they are going to be responsible for producing the testosterone. Okay, right. Now the LH will bind to lady cells, which is also the interstitial cells within the interstitial compartment, and then they will lead the testosterone production. Very simple. So Sertoli cell will also be producing the androgen binding proteins, which will function as receptors for the testosterone. This is also well captured already. You said over and over again that the ADP, which is the receptors for the testosterone, will sequestrate. And remember, what is the common name for EDTA in hematology? EDTA. What's the common name for EDTA? Who can tell me the common name for EDTA?
Chelating agent.
Yes, that's the action or the mechanism. I'm talking about a common name for the chemical EDTA. You know it's called sequestrin.
Yeah.
Who knows that? Who knows? You don't know?
Yes, sequestrin agent.
You don't know, eh?
Hello?
You haven't heard about it before. That EDTA is called sequestrin.
Yeah, that one.
Who has idea about EDTA being called sequestrin?
Yeah. No.
You haven't heard about it before.
Zona.
Nobody has heard about the fact that EDTA is called sequestrin.
Guara.
That's bad.
We made mention of it during the embryology time.
Okay. So EDTA is called sequestrin just because the action The EDTA will chelate, like somebody said, will chelate, and chelating means like binding the calciums. I know that in the coagulation cascade, you need calcium. So if you bind all the calcium, then it means that calcium will be unavailable for the coagulation, and therefore the system will remain uncoagulated, and for that matter, anticoagulant. Okay, so to sequestrate means to bind. Okay, to bind. So ABP is binding testosterone. So you can say that testosterone has been sequestrated. And once you sequestrate, it means that you are concentrating the testosterone in the tubules. So that's how can you have high intratubular testosterone. And once the tubules are in the testicles, you can also say you have intratesticular testosterone. I try to bring all these technicalities so that wherever you find yourself, okay, anybody can talk about the same thing using different technicalities, and you will not be bothered because you understand what the person is talking. That's how come you went to the down regulation in hormones and then up regulation and so forth and so on. So ABP is said to sequestrate, and I thought that, I always say that the best way to learn is to start from what you know already, and then you move into what you don't know. I knew that EDTA as sequestering is fundamental. Even laboratory assistants are taught that EDTA is called sequestering, and it's based on the action or the fact that EDTA works by binding to the calcium in the system. And once calcium is unavailable, blood will not clot. That's the action, the mechanism of action for EDTA. So I thought that you were very, very familiar with the concept of sequestration. Right. So ABP is serving also as a sequestrant. All right. So, and you said already that the intratesticular, if you say intratesticular and you also come across intratubular, they are the same thing. But intratesticular is saying that it's from the testicles. Intratubular is being specific. That yes, within the testicles, you are talking about within the tubules. So if you come across intratesticular testosterone, and somebody talks about intratubular testosterone, they are the same thing, except that one is being more specific. All right, good. And we've said also again that testosterone production does not remain constant throughout the day, but follows a circadian rhythm, with the maximum peak of testosterone occurring around 8 a.m. You remember when we were doing andrology, which mentioned that if you want to check your testosterone level, you don't do it anytime. You should know about the fact that the testosterone shows a circadian rhythm where it is highest in the mornings, and then as the days goes by, it comes down. Okay, right. So this is just like a revision of what you've done already. Now, testosterone level naturally decrease with age, okay, due to a decline in lady cell activity as males get older. So as males get older, the lady cells which produce the testosterone, the activity go down. That's natural. And so once the activity of lady cells go down with age, the testosterone level will automatically go down. And that's natural. That's how come, let's say, sperm production can go down with age, but it doesn't stop. It doesn't stop. All right. Other conditions or circumstances which may cause low testosterone include testicular injuries. Of course, if you have testicular injuries, it may affect the functionality of the Leydig cells and so forth and so on. Well, so that is, we also talked about how obesity affects testosterone production. We said this long in the previous lectures. So this is a summary of the hormonal regulation. So you talk about the gonadotropin releasing hormone, the fact that's coming from the hypothalamus, the fact that it stimulates FSH and LH release from the anterior pituitary. All right, so they actually will stimulate the anterior pituitary to produce LH and FSH. Okay, so the LH, which is also called the interstitial cell stimulating hormone, I intentionally brought this one because I want you to be very, very familiar with ICSH. Once I know that some people, once some doctors write ICSH, they'll tell, oh, we can't do this test. If they come around and notice that it is the same thing as LH, so, oh, I didn't know it. That would be very bad. So along the program, we have mentioned a number of times how come LH is called ICSH. It's coming from the anterior pituitary, and they also stimulate the Leydig cells to produce testosterone. FSH, of course, also coming from anterior pituitary, and along with testosterone, stimulates the spermatic cells in the tubules to produce sperms. Then, of course, testosterone coming from the testes of the Leydig cells, so specifically in the Leydig cells, they promote spermatogenesis and secondary sexual characteristics, and they feed back to the hypothalamus and pituitary to reduce gonadotropin releasing hormone secretion to the pituitary, and therefore automatically reduce LH production by the pituitary. This one is just a summary of all the talk that I've done so far. And inhibin, you said that inhibin is specifically from the Sertoli cells, and they inhibit FSH. They feedback on the pituitary and not on the gonadotropin releasing hormone. All right. And the feedback on the pituitary, and their effect is more on reducing FSH than on LH, even though pituitary is producing both LH and FSH. We'll talk a little about endocrinopathies. Endocrinopathies, and wherever you see pathology, it's a disease condition. So you can talk about endocrinopathy. That is one disease. Once it becomes diseases, as much as you know, that becomes pathy. So endocrinopathy, you're talking about diseases associated with hormonal activities. All right. So that is endocrinopathies. And here we are still dealing with we are still confining ourselves to the HPG. And with HPG, you know that we are not going beyond FSH and LH and then testosterone, and so forth and so on. Right. So in endocrinopathies, that diseases affecting the hormones, you actually have a lack of the hormones or excess of the hormones. Okay. So when you have a lack of the hormone, okay, it gives you a disease condition. Similarly, if you have an excess of the hormones, you still have a disease condition. Okay. Now, and typically, if you have hypogonadism, like we said over and over again, in hypogonadism, they're talking about a situation where the Leydig cells are not producing enough of the testosterone. All right, so that's hypogonadism. So if you have hypogonadotropic hypogonadism, I'm sure you should be able to understand this. Hypogonadotropic. Gonadotropic is, they are the hormones that are supposed to hit the testes. Remember that. The hormones that are supposed to hit the testes, they are the gonadotropic hormones, and they are the LH and FSH. If you have hypo, it means that you have reduced amount of LH and FSH. Once you have reduced amount of LH and FSH, automatically you have a reduced amount of testosterone. If you combine all of it, it becomes hypogonadotropic hypogonadism. I don't know whether somebody got me right. So that if you have hypogonadism, it means that the gonads, and for that matter, testicles is not producing enough of the hormones. What hormones are you expecting the testes to produce? It's the androgens, and for that matter, testosterone. So if you have low testosterone, that is described as hypogonadism. Okay. Then you are talking about the stimulants, the hormones that are supposed to stimulate the lady cells to produce. If their levels are also low, then we are also talking about hypogonadotropic. So it means that the hypogonadism is as a result of low levels of the low levels of the gonadotropic hormones. Then that will also give you a hypogonadotropic status. Then you can now merge the two. If you merge the two, become hypogonadotropic hypogonadism. Please, does anybody have a problem understanding this?
Yes, sir.
Are you okay with it?
Yes, sir.
Hello? Are you okay with the explanation?
Yes, sir.
Okay. So in hypogonadotropic hypogonadism, you expect your LH and FSH all to be low. And of course, testosterone is also low. Okay. So remember, we said that if testosterone is low and FSH and LH are all normal or even left high, then that is primary hypogonadism. You mentioned that already. So causes of HH, which is hypogonadotropic hypogonadism, could include a damage to hypothalamus. Because remember that the hypothalamus will have to release the gonadotropic releasing hormones to the pituitary to also release the LH and FSH. So if the hypothalamus is injured or damaged or is defective, automatically the gonadotropic releasing hormone, LH and FSH, all of them will go down. And once all of them goes down, of course, testosterone will also go down. Then, of course, that can explain the cause of your HH, which is the hypogonadotropic hypogonadism. Okay. So anything that is affecting the activity of the hypothalamus, which will include an injury, surgery. These days, a lot of the neurosurgeons are able to work on the brain. If you are not lucky, and then the hypothalamus and then the pituitary glands are damaged to some extent, of course, unintentionally, then at the end of it all, you are going to have hypogonadotropic hypogonadism. Okay. Then we have the hypogonadotropic hypogonadism. You should be able to explain this one. The hypogonadism, already you understand it, that low level of testosterone, that's a low activity of the gonads. But here we are talking about a situation where LH and FSH are all normal. They are all normal. Then even higher. Once they are higher, then we are talking about hypogonadotropic status. Even though they are normal, yet testosterone is also low. Then that becomes hypogonadotropic hypogonadism. Okay. In that case, it means that the problem is coming from the testis itself. If you have a testicular damage, then you can have hypogonadotropic hypogonadism. All right. And this will include testicular torsion. You remember when we're dealing with the testis, the condition, you talk about testicular torsion where testicles, especially the spermatic cord could turn. And once it turns, blood flow to the testes can be compromised, and that could lead to damage to the testicles. And once testicular damage happens, of course, you should expect its activity, which includes testosterone production, to go down. Once it go down, then that's a typical hypogonadism condition. All right. We have also mentioned this hyperprolactinemia can cause male infertility due to its inhibitory effects on the hypothalamus. Remember, we said that prolactin is also produced from the pituitary. The same point, the same source is also producing the LH and FSH. So anything that is affecting the gonadotropin releasing hormones can also affect the production of prolactin. So if you have high prolactin level, just as you have high testosterone level, it will negatively feedback on the hypothalamus. Okay, once the feedback on the hypothalamus, automatically is going to have a reduction or down regulate the LH and FSH, and of course, low testosterone. So if you have a situation of hyperprolactinemia, of course, automatically you should expect that if you have hypogonadism. Good. The same thing happens with the thyroid. I mean, talking about all these things because if you're doing investigation for hormonal effect on sperm production, that's how come you see a doctor also requesting for TFT, thyroid function test, and also prolactin. And you ask yourself, why is the doctor doing thyroid function test or prolactin test for a patient who is only having low sperm count? If you're having a low sperm count, you want to find out whether the testicular function is all right. If testicular function is all right, then testosterone level should also be okay. If testosterone level is okay, then the FSH and LH should also be okay somehow. So you want all other things that can also affect the production of LH and FSH. And this includes the prolactin and then the thyroids, like I've said already. So thyroid hormones act on testes in multiple ways, and they exert their effect on the Leydig, Sertoli, and the germ cells. Okay, so here the thyroid, the thyroidism is known to also influence the cell division of the Sertoli cells. Remember, the Sertoli cell itself is also a cell, and therefore it must also survive. One of the things that it needs to survive, to work on, is thyroidism. So if Sertoli cell is defective, of course, you should know that sperm count or sperm production is going to be severely compromised. You know the role of the Sertoli cells. So if Sertoli cell can work very well, it must be healthy. It must also be able to also survive. And they survive on thyroidin, which is a T4. So if you are doing investigation for low sperm count, it is important to look at all these things. All right. So immature Sertoli cells is incapable of supporting germ cells. So I hope you know that. Sertoli cells, if they themselves are not mature, okay, then they cannot, if they have to support the germ cells and the Sertoli themselves are immature or they themselves are dysfunctional, they cannot do anything. So therefore, thyroidin, which is required by Sertoli cells to mature, should also be in abundance for them. Okay, so that's how come thyroidin have effect on indirectly on the sperm production. Okay, all right. So this thyroidin, I intentionally brought this thing so that you understand some of the terminologies. This thyroidin refers to defective thyroid functioning. So this thyroidism is the functioning of the thyroids. This thyroidism, that is a malfunctioning or defective function of the thyroids. So if the thyroid is malfunctioning, it is the fact that either it is performing below expectation or above expectation. Okay. Either way, if it's overproducing, thyroid is overproducing, that is hyperthyroidism. If the thyroid is underproducing, that is hypothyroidism. Okay. Either way, whether it's hyperthyroidism or hypothyroidism, they also affect the sperm production. Okay. So we are having last slot so that quickly we will finish with this session, and then we start another session next week. So now we have adequate information about how sperm is produced and all that can affect it and so forth and so sperm have been produced. Then how is it transported? Remember we said that once the sperm are produced and they are at the end of the day, they have to pass through a phase called spermiation, where they will now have to be released by the Sertoli cells into the lumen. Remember we said that at that point, they are only structurally mature. That is, at that point, they will have their head, their neck, and then the tail. They have everything. That is structure, morphologically, you can say that they are complete. But the essence of sperm is to be able to move and then also be able to fertilize a female ovum or an egg. So if you have a sperm which is structurally normal, but cannot move and cannot fertilize an egg, then that is also, we call that functional immaturity. You're functionally, you are not mature. Okay, so let's see how they attain maturation. So now we've seen the sperm from the germ cell throughout to now become a mature in quote, or into inverted commas, because they are mature structurally. I want to repeat that. Within the testicles, the sperms are mature in structure, but functionally, they are immature. All right, so this is our next topic. So that's sperm transport and maturation. So sperm released into a lumen, we also call it testicular spermatozoa. That's the sperm which have just been released from the testicles. But they are structurally mature, but functionally immature, like I've explained. Now, so the testicular spermatozoa, they lack the ability to move, and they also lack the ability to be able to fertilize an egg until they move through the epididymis. All right. So now let's see what is called the intratesticular system. So remember that at the end of the day, the sperm will have to move outside the body into the female. Okay, but from the point of production, it has to move through certain ducts, okay, before they even come to the epididymis. And then from the epididymis, they'll move through the vas deferens and then into the prostate area, and then so before they come out. So within the testicles, they move through certain ducts. That's what we call the intratesticular system. That network, you have to be able to understand it. So the sperm transfer within the intratesticular system start with the straight tubules. You remember that we said that the seminiferous tubules, they have the convoluted section and they have the straight tubules. That section don't have germ cells. So all the germ cells that will also now have the Sertoli cells, and that will also perform the function of sperm production. They are all within the convoluted tubules. Now, so once they have finished their duty, the sperms will have to move through the lumen. Then they will go to the straight section of the seminiferous tubules. So it means that the transport, the movement, will start from the straight tubules. If you say straight tubules, you are talking about the straight seminiferous tubules. So that's the point, because within the convoluted tubules, there is still production. But the straight tubules, there's no production. It's just a matter of carrying along with what has been produced within the convoluted tubules, right? So for the straight tubules, they lead to the erected testis. Remember this, before entering the efferent ductals, which then will propel into the epididymis for maturation. All right. So Sertoli cells in the seminiferous tubules produce the fluid that helps the that helps move the immature, because now we're saying that the sperms cannot move. So there must be a certain liquid or fluid within which they will not swim because they cannot move. But there's a fluid which is called testicular fluid produced by the seminiferous tubules. So you see that, sorry, produced by the Sertoli cells within the seminiferous tubules. Okay, then they will provide that fluid for, and then they will also provide contraction by peristaltis. I'm sure you know peristaltic movement. Hello? Do you know peristaltic movement? Is there anyone who has no idea about peristaltic movement, contractions? Hey, as for this silence there, I don't know. Look, I keep on saying, you see, your basic sciences, you shouldn't forget about your basic science. Okay, yeah, okay. So you see that the sperms cannot move. So the seminiferous tubules will provide a fluid, and then it means the only means that they will move is through peristaltic contraction. Okay, so peristaltic movement is what is used to move the sperms along, because at that point they cannot move on their own. So that's by peristaltic contraction, and then they will move to the red testis, and then efferent ductals, and then to the epididymis. And if from the epididymis, you know that start from the head of the epididymis to the body to the tail, and then from the tail they can now join the vas deferens. You should have that picture in your mind. All right. So this is it. So, you know, these are the lobules, and within the lobule, each lobule, you have the seminiferous tubules. Okay. Then the seminiferous tubules, here, they are all convoluted. Here, they convolute as curves. And then here, they are straight. So you have the straight tubules. They are all part of the seminiferous tubules, but this side is convoluted and this side is straight. So we have here as the straight tubules. And then from the straight tubules, you go to what we call the red testis. The red testis, these ones, the semitoid will join to form the red testis. Then from the red testis, you come to the efferent ductals, or the ducts. The ductals, because they are much smaller than ordinary ducts. So you can have efferent ducts or efferent ductals. And then from here, they are joining the head of the epididymis. Okay. And then from the head of the epididymis, they also move. And then there's the corpus, that's the body. And then here they come to the head. Sorry, the tail end. And then from here, they will join the vas deferens. So the movement we are talking about is from the seminiferous tubules here, then they come to the straight, to the red testis, efferent ducts, then to the epididymis. Here, we are going to discuss extensively. So this is within the epididymis. The movement with the epididymis is also quite different from the movement here. All right. So we call this one the epididymal transit. The sperm transport itself will be from here, from the point of production, right through this one, coming here to the vas, and then to the outside. Now, we are now tackling this aspect, which is the epididymal transit. Okay, epididymal transit is very, very important. So epididymal transit is the crucial phase where the sperm moves through the epididymis for several days to become matured. And then they acquire the capacity to move and then be able to fertilize an egg. And so that is what we call functional maturity. Remember, you said that from the testes, they are mature structurally, but they are functionally immature. They acquire their maturity through the movement through the epididymis. Okay, so sperm in the epididymis are moved through the coils of the epididymis by peristaltic contractions. All right, because as of that time, you still don't have the they still don't have the capacity to move on their own. Okay, right. So as sperm transit through the epididymis into the vas deferens, they also undergo concentration. We are going to talk about how the sperms undergo concentration. They also undergo or have some protection, how that happens. They have motility, they have maturation, they have storage. So all these things happen within the epididymis. Okay, and all these take between 10 to 15 days. All right. So what is the sperm concentration? Not the sperm concentration as in sperm count. No, we are saying that the sperm cannot, from their testicles, they cannot move on their own. So we have the seminiferous tubules, within the seminiferous tubules, they are provided testicular fluid by the Sertoli cells to move them along like a stream of water. So by the time they get to the head of the time they get to the head of the epididymis, there's a lot of fluid. Okay, there's a lot of fluid. So what happens is that the epididymis will have to absorb all the testicular fluid. So once they absorb the testicular, if you have sperms or like cells with a lot of fluid, if you remove the fluid, what will happen? What do you think? If you remove the fluid, what are you trying to do? Somebody should talk. They're talking about concentration. I'm saying that the testis, from the testis, the sperms are moved to the epididymis with a lot of testicular fluid. Once they get into the epididymis, and the epididymis absorb the extra testicular fluid. So once they do that, what will be the end effect? Hello, my dear people. Are you hearing me, please? Are you following me and hearing me?
Yes.
Okay, so
Yes,
I'm
please.
saying that the fluid that comes along from the seminiferous tubules area to the epididymis, they are all absorbed. So once that happens, what is its effect? You are concentrating the cells. Yeah, you see, if you have cells, okay, if you have cells in a certain amount of fluid and you take off the fluid, the cells become concentrated. That is it. It becomes concentrated so that now if you have a cup, okay, a cup of let's say a cup filled with water, and you have some let's say grains of something in it. If you remove the water from it, at the end of the day, you are going to get the whatever you had concentrated, because the amount per mil of the resin will have become very, very high. So that is concentration, and that is a function of the epididymis. The epididymis will remove all the extra fluid that you came along with it. It will take them off. It will absorb all of them. So the sperms become highly concentrated. Okay, so that's sperm concentration. All right, so that any small amount of specimen that you take from there is highly, highly concentrated. Okay, because the fluid component has been taken off. All right. So sperm concentration. The sperm concentration in the epididymis is necessary.
Because near tono, what 3 1 week, and 1 week bomb 3 days penance.
Okay, so then we also have the sperm protection. So I'm sure you understood the element of concentration. That's also a function by the epididymis. Then there's also sperm protection. Remember, we said that one of the things that happens that denatures denatures sperms is the effect of oxidative stress. And we said that oxidative stress, we're talking about the excess reactive oxygen species. And reactive oxygen species, they are everywhere. Any metabolic activity that takes place in the body is effect. So the byproducts could include a reactive oxygen species, because you wouldn't get end product always giving you oxygen, O2, O2, O2. No, it doesn't happen. You get the singlet form of oxygen, the superoxide form, the hydrogen peroxide form, and we said that all those collectively are the reactive oxygen species. So they will be everywhere. Wherever there's an activity, metabolic activity, you have a reactive oxygen species. And so within the testes, within the epididymis, you have antioxidants that will also try to take off any excess reactive oxygen species. And once you take off the oxygen reactive species, what happens is that you are reducing oxidative stress, and therefore a damage to the sperm cells are reduced. So once you also reduce the damage to sperm cells, what are you doing? You are protecting them. So that's also a protective mechanism by the epididymis. Within the epididymis, as the sperms are traveling through, they are protected by having additional oxidative antioxidants to take off any excess, what do you call it, reactive oxygen species that will endanger the structure of the functionality of the sperm cells. So that is it. And also, we also talk about blood epididymis barrier. Just as we talk about a blood testis barrier. You see, the sperms must also be protected at any point in time. Now they have moved away from the testis. They are in the epididymis. Okay, they are in the epididymis. And they are going to be stored in the epididymis. So if they are also not protected effectively, they will also get the blood system will have effect on them, and they can also have anti-sperm antibodies. So there's also blood epididymis barrier, okay, within the epididymis structure. So once you have it is also providing a protection. So you have double protection within the epididymis. So you have the blood epididymis barrier protecting them from any access to the immune system, and then also having the abundant antioxidants to take off any reactive oxygen species that could also cause damage to the sperm. So you see that that's also a very, very important action by the epididymis. There's also what we call decapacitation factors. You see, we know that we are not doing the female aspect of reproduction, but you see, once the sperms goes into the female reproductive tract and they get access to the ovum or the egg, we know that the head of the sperm have a cap on it. That cap is called acrosome. What is contained in that acrosome? What is contained in that acrosome?
The nucleus.
No.
Not the nucleus body.
No. The acrosome is covering the nucleus. Okay. The nucleus contains the genetic material. But what is contained in the acrosome? They did the gel 2 days ago. It is coming from the Golgi bodies. The Golgi contains hydrolytic enzymes. They contain hydrolytic enzymes. Okay, or the lysozymes. They contain that. And so once the acrosome is there, once the sperm get to contact the egg, as soon as they touch the shell of the egg, which we call pellicle, the acrosome will burst. The acrosome will release its hydrolytic enzymes. Once it releases its hydrolytic enzymes, what will happen is that they cause like ruptures or spaces within the covering of the distance, so that the egg can the sperm can move into the egg. Okay, that's called capacitation. So it is also called acrosomal reaction, because if that doesn't happen, there's no way the sperm can enter into the egg. And if the sperm doesn't enter the egg too, it's like I can't say they say huye or you know huye, butterfly. once a butterfly lands on a tortoise, what can it do to it? It can't do anything. So if you have a sperm getting close or getting in touch with an egg, if there's no acrosomal reaction, it will not happen. It can't go inside. It can't go in. It is the acrosomal reaction which will release the hydrolytic, the lytic enzyme, the lysozymes, which will be released for it to now like melt or disrupt as an area or the eggshell, some part of it, so that it can penetrate. And like I've said, that's called capacitation. And the capacitation is also called acrosomal reaction. If that doesn't happen, there's no way an egg, so a sperm can enter an egg. Okay. So what it means is that within the epididymis, if you don't take care and the reaction starts there, the acrosomal reaction also happens there. Then it means that the acrosome is also now going to the acrosome, which is contained of the lysosomal enzymes, the hydrolytic enzymes, will also be released and destroy everything. So the enzyme, the epididymis also produce what we call decapacitation factors. You see, we have seen that the activity of the acrosome by reacting and releasing its hydrolytic enzymes or proteolytic enzymes is called capacitation. And when you say decapacitation, what it means that you are removing the ability to capacitate. Please, are you hearing me? Are you understand? This is high level science. Please. It's high level science. So you have to be able to also understand it. That makes you a scientist. They're saying that the acrosome can undergo a reaction called acrosomal reaction, which is called capacitation. And it is this capacitation that allows the sperm to be able to enter into the sperm, into an ovum, an egg, that is in the female reproductive tract. So what we are saying is that it's like somebody who is moving and has a gun which is cocked. Okay, and it's supposed to be able to shoot once an enemy is around or something. But within the space where all of us are moving, if nobody is tracking that person, the person can inadvertently begin to shoot and then kill themselves. So within the epididymis, the acrosome must be protected. Okay, must be protected. So you have certain factors that will not allow capacitation, which is the acrosomal reaction, to take place. And that's called decapacitation, because we're saying that the acrosomal reaction is called capacitation. So decapacitation is trying to avoid or remove the ability to capacitate. So those are factors that are released or available within the epididymis. So it means that the epididymis is also providing a sort of protection for the sperms and even for the entire population of the sperms. Because if all of them, they begin to show that kind of acrosomal reaction called capacitation, then they will destroy themselves. Okay, because the acrosomes contain the elements that are coming from the Golgi apparatus or the Golgi bodies, and they are the the proteolytic or hydrolytic. In fact, when we say lytic, we break down. So they are able to break down a whole lot of things, including proteins and everything. Okay, so that is very, very, very important. So that within the epididymis, no such capacitation reaction takes place. And so that is also a protection by the epididymis. And then the last one, the maturation. So sperm maturation, that's a physiological process where the sperm will acquire capacity to fertilize. Okay, and then so that one, by the time the sperms move through the entire body of the epididymis, they will have gained the ability to to be motile. Okay, to be motile. All right. So these are and that is how the sperm become mature. So the sperm maturation process typically occurs in the corpus. Remember, we have the caput, which is the head, and then the corpus, which is the body itself, and then the cauda, which is the tail. By the tail end, by the time you reach the tail end, they are already matured, and that is where they are stored. And the storage will now take them to the vas deferens. So acquisition of sperm motility capability. So sperm entering the head of the epididymis are moved through the coils of the epididymis by the peristaltic contraction of the smooth muscle lining there. So once within the epididymis, once they are being moved through peristaltic, it's like it's becoming a learning process. So by the time they move from the head to the tail, they will have been able to move. Okay, right. So in all of this, the sperms gain motility, but they don't move. They gain capacity to able to fertilize, but they don't. They are held in check. Okay, so all those things are very, very important processes that occur in the epididymis. So otherwise, in the epididymis, look at the millions of sperm that are being produced. If everybody is moving, then, but there are certain specific proteins that will put them in check so that, yes, you know how to run, but you are not going to run at this time. Okay, right, that's what is happening. So you'll be held in check. You know how to undergo capacitation, but you will not be allowed to undergo capacitation. But the fact is that they will have learned all the things that they're able to do, but they don't put them in practice at the point that they are within the epididymis. So epididymis is serving like a master control for all those activities. Good. And then of course the storage, so that finally at the tail end, the sperms are becoming functionally mature and they are stored. Okay, right. The sperms, once they are stored, every moment, every second, new sperms are being produced and new sperms are being stored. What happens is that if they are stored for a very long time and they are not being ejaculated, two things can happen. Once they are not being ejaculated, they die. Some of them will die, and once they die, the cells of the epididymis have a capacity to reabsorb them. Remember that when they came along with their testicular fluid, the epididymis reabsorb all the fluid. If there's anything which is any sperm die within the testicles, a lot of them are reabsorbed by the epididymal cells. Okay. And then, of course, you know also that when the sperms are stored for a long time, some of them are able to move through by peristaltic movement, move through the vas deferens and get into the prostate area there, through the prostatic urethra, and of course they become part of the urine. Okay, so if you for a long time you don't ejaculate, sometimes you do urine RE and then there are a lot of sperms in there and it's normal. It only speaks about the fact that the person has not ejaculated for a long time. Okay, right. So that's about the sperm storage. Then, so now that we've known how the sperm had moved from the production site up to the epididymis. All right. So at the epididymis where it has been stored, what happens? Then here we can talk about sexual arousal, where there's going to be emission. Emission is, we talk about emission, where sperms through peristaltic movement and contractions are also able to move from the stored area also into the prostatic urethra. Okay, and then expulsion is where they are also taken out. So during sexual arousal, peristaltic contractions in the vas deferens propel stored sperm toward the ejaculatory ducts, driven by stimulation from the sympathetic nervous system. You remember that one that we did. So the sympathetic nervous system will promote ejaculation, all right, and not erection. And remember that sympathetic nervous system is anti-erectile. So once it is promoting the ejaculation, at the end of the day, they also cause your flaccid penis to occur. So during the sexual arousal, then the sperms will move from where they have been stored to the ejaculatory ducts and then to the urethra. And then, of course, they are out of the system. So now you have the sperm travel through a series of ducts from the production to the expulsion in this order. From the straight tubule, I hope you remember the straight tubule. The straight tubule is immediately after the convoluted tubule. You have the straight tubule, you have the red testicles, they move to the efferent duct, you have to the vasa efferentia, epididymis. Indeed, the epididymis, then they are where they undergo maturation and storage. Then during ejaculation, they will move from the epididymis to the vas deferens, then to the ejaculatory duct, to the urethra, and the outside. So this is this picture of the whole thing. So you have within the testes, so while sperm produced in the testes, then they are transported through the red testes, blah, 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 to the epididymis. Okay, and then from here, during sexual arousal ejaculation, they are transported into the prostate area here, and then they come out and then out. Ladies and gentlemen, it's been a long talk, but I hope that this has been very interesting. So we are done with module 1 of the Semenology section. I think we have about 4 modules to go. So I'll try and do my best. So if you have any question, please do ask. Yes, sir.
With the diagram displayed now.
The diagram.
Yes.
I should explain.
No, I mean, I'm making reference to the MCQs we have.
The previous one or this one?
No, I mean this one, the MCQs we have. I'm making about a particular question.
Okay.
Which was asking for the location of the prostate gland. But
location of what?
The prostate gland.
Okay.
The possible answers had the seminal vesicle, the epididymis, the bulbo urethra, and then the gubernaculum. But apparently, it was saying the seminal vesicle was the incorrect answer. I wanted to verify. We're looking at the diagram.
Now this diagram is abridged. This diagram is abridged. A lot of things have been taken off. Okay.
Sure.
So we are dealing with the sperm transport. Remember that before this point, we have even talked about the intratesticular transport. Then we did the transport through the epididymis individually. So this becomes a summary. Okay, so in summary, we have the sperm produced within the seminiferous tubules. Okay, and like I said, from here to the epididymis, I think we have done with it extensively. Okay, and then from the epididymis, the sperms become stored. Okay, stored until during ejaculation. And then during ejaculation, they move through this into the prostate. You know, the urethra, you have the prostatic urethra. All right, so the section, then the membranous and the spongy urethra, you know all those terms in the andrology class. Now, over here, before they come to the before they get to the ejaculatory duct here, then the the seminal vesicles will also have produced their seminal fluid and then come and join here. And then as for the bulbo urethra, it is somewhere down here. Okay, under the penis here. It is not here. Our emphasis was on the sperm, not the semen itself. So I'm sure that's how kind of things we didn't bring here. We are talking about the sperm transport, not the semen. So if it comes to semen, then of course we are going to bring all the accessories and how they also add up to make up the semen. Is that all right for you? Or maybe I didn't understand your question well.
Yes. My question was on the MCQs we have. The question
NCP.
was, I mean, the MCQs we had on the
The
anthology.
MCQs. Oh, okay.
Yes. The question was, the prostate gland is located below. And then the possible answers were the global urethra, the seminal vesicle, and then the big. After choosing the seminal vesicle as the answer, I think you were marked down as.
Oh, that one cannot be that. They're talking about the prostate. It's just
Yes.
below the blood. It's just below the bladder.
Yes, but bladder wasn't part of the possible answers.
Okay, I'll look at it again. I'll look at it again.
Okay.
Okay. All right. Thank you. Sorry. I thought we were talking about this one.
Yes, sir.
Okay. So once we meet, when we meet on Monday, I will have reviewed the question again and see the one we're talking about. Okay. All right. Thank you. Any question, please? All right. So you get the slides in the course of during the weekend, and then we start another session on Monday. Okay. I wish you all the best.
Thank you.